The future of psychiatry depends on members who are willing to lead. APA's call for nominations is now open, and we invite you to nominate yourself or a colleague for leadership and volunteer opportunities. Help shape the future of our profession. Visit psychiatry.org/elections. Nominations close September 1st.
All right, everybody, welcome back to Psychiatric News Special Report, August 2026 podcast. We are having a great discussion today with Dr. Rajesh Tampi. This is his article that he came out for the special report. It's evidence-based management of behavioral symptoms of dementia. I'm the host for the show, Dr. Sulman Aziz Mirza, triple board certified adult psychiatry, child adolescent psychiatry, and addiction medicine. And this article to me is a reminder of why I went in to become primarily a child and adolescent psychiatrist. This is the opposite spectrum of what I normally work with on a day-to-day basis, but it's something that I think a lot of people, maybe in my shoes or not, in regards to don't want to think about it. You know, it's hard as like sometimes as a psychiatrist to be like, do I want to be working with dementia patients? Is it a helpful? How much help can I be for a lot of caregivers? It is definitely a huge, huge burden, perhaps. And then, of course, the people who are going through it themselves, like it's obviously very, very difficult. So again, like we have Dr. Rajesh Tampi with us here. He is the author, one of the authors for the paper. Dr. Tampi, welcome to the show. How are you doing?
Thank you, Dr. Mirza. Thank you. I'm glad to be here talking about a very important problem in geriatric psychiatry, that is behavioral and psychological symptoms, also known as neuropsychiatric symptoms of dementia.
Yeah, tell us a little bit about yourself, your background, and what led you to put this article out for us.
Yeah, so I'm a board certified geriatric psychiatrist. I'm the past president of the American Association for Geriatric Psychiatry and its inaugural historian. In my day job, I am the chair of psychiatry here at Creighton Medical School in Omaha, Nebraska.
Like,
So why is it important? Because we are an aging society. For the first time in the history of the world, we have more people above the age of 65 than under the age of 5. By 2035, we will have more individuals over the age of 65 than under the age of 18. So other than being a child psychiatrist or a pediatrician, you are going to be dealing with these kind of individuals because most of the patients that you see in hospitals are older. They have polymorbidity. They may have neurocognitive disorders, and behavioral symptoms are inbuilt into the natural history of the dementing process. So this is not very separate from the cognitive issues. This is inbuilt into that. And as we discuss, it'll become much more clearer to you.
yeah. So one of the things when I was going through again, like I'm primarily a child adolescent psychiatrist, when I'm reading the article and you kind of briefly touched on it, the scope of the issue. So some of the prevalence numbers, I guess, like a third of community dwelling patients are going to have some of these concerns.
Right,
80% of those in nursing home are
right,
going to have these concerns.
right.
90% will develop these disorders during the course of the illness, right? So
Correct.
it's like
90% or more. Yep.
or more.
So,
Yeah.
yep. So as what we know is that, so first of all, people misunderstand dementias or what now in the DSM-5 TR or the DSM-5 and the DSM-5 TR we call as major neurocognitive disorders. So these are neurocognitive disorders. These are not memory disorders alone. So, people misunderstand. So memory disorder is amnestic disorder, whereas dementias are much more than that. So they have cognitive decline, uh, and then they develop functional decline, and then behavioral symptoms can emerge at any time during the life history of the illness. That's why over 97% will have over 90% will have these behavioral symptoms sometimes during the course of the illness. But it may be the first sign that the patient is having a neurocognitive disorder. So it may be the heralding sign. So people may become apathetic. That means they're withdrawn, not initiating activities, so not interested in doing anything. That may be misperceived as being depression, but the underlying issue is the neurocognitive disorder. So it can happen at any time, and the magnitude. We have a number of individuals who are older now, probably 45 million individuals over the age of 65, and that number is going to rise significantly and almost double in about 20 to 30 years. And a significant number of these individuals will have cognitive issues because neurocognitive disorders are more common as people age. So age is the number one non-modifiable risk factor for these disorders. So as this population ages, more individuals will have neurocognitive disorders. 30% of individuals over the age of 90 will have neurocognitive disorders. Centenarians, 75% will meet the clinical criteria. So the numbers are large. And then these are quite important because they not only, as you read through the article, you realize that they not only increase morbidity, they increase mortality rates, cost of care, burnout for the caregiver. So it adds to the complexity and the magnitude of caring for these individuals. So it's not simple. It's important. We all need to know about it. And then, as science progresses, we will have medications, a group of medications that will help slow down the progression of the illness. And now newer medications are coming out, some medications that are being repurposed for treating these behavioral symptoms. So I think it's important as a healthcare provider to know about that. So at least you can ask for help.
And I think it's really important. One of the things that you mentioned was that sometimes that behavioral symptoms are the heralding symptoms,
Yeah.
like the first
Yeah.
thing that we see ahead of sometimes the cognitive decline. I think there's a lot of focus in healthcare and in the media about like, oh, cognitive deficits and grandma's losing her memory and grandpa's, not the same as he was before. But I think the thing that really gets families really involved is like when we have the behavioral symptoms more so than anything else.
Right.
So
So behavioral symptoms, a third of the cost of caring for individuals with neurocognitive disorders is because of behavioral symptoms. The most common is, of course, the functional decline. The issue is that the behavioral symptoms not only affects the individual, but it affects the whole ecosystem around that individual. Caregiving becomes a caregiving career because people with dementias and neurocognitive disorders are now living much longer, more than a decade. So people who are caring for them are also aging. So what happens is it adds to the burden of caring for those individuals. And the caregiver burden leads to worse outcomes for the caregivers themselves. They become depressed, they have more cardiovascular morbidity. So you really need to take care of these individuals around them. And when it is the heralding sign of the neurocognitive disorder, may have to deal with these symptoms for a decade, 2 decades. So it is a really long haul, and you really need to know how to manage them. That's what is called the A, the B, and C's of neurocognitive disorders. A is the activities of daily living, B is the behaviors, and C is the cognition. The cognition declines, the activities of daily living decline, and then behaviors can emerge at any time. So when you are seeing an older patient in your clinic, you should be cognizant of those three facts. Whenever you're seeing a patient for depression, if they're older, you also have to say, okay, how is your cognition? How is your functioning? Are there any things? Because the depression that you're seeing may not be the depression per se. It may be the depression occurring because the neurobiology of the brain is changing and you're now starting to have the neurocognitive disorder. But because, we have such short time to assess patients, everybody just treats what is right in front of your eyes, but they don't work up the patient properly.
yeah, which is an important point that I always kind of bring up is that the healthcare system environment and kind of the pressures that are out there, especially now of us, that makes it really hard to kind of do that thorough evaluation.
Correct.
Which I thought was again another interesting part of the paper was that again going back to my residency training, last time I was really working with patients with dementia directly as as a provider was you, it becomes like this algorithmic knee jerk step. So you hear dementia, you hear agitation, you go antipsychotic.
Right.
and you hit them with some Haldol or you hit them with some olanzapine or you do something like that, and boom, that should take care of it. And it's like, we know that's not the best treatment. So
Correct.
talk to us a little
Correct.
bit. I really like that there was a kind of almost like a hidden, not a hidden, but like a, the biopsychosocial environmental plan that we have to put in place for how we manage this. So talk to us
Correct.
about that a bit.
So
Yeah.
the important thing, that's a very, very important point that you bring up, is that one size does not fit all. And I think we're so busy in the numbers of patients that we see and generating RVUs. I think we've lost touch with what's the real problem. The patient sitting in front of us. It's a human being. It's a family member who's suffering. We need to really alleviate suffering. I always have this pet peeve when people call me a provider. I'm not a provider. I'm a healer more than anything else. I heal. I don't prescribe. I do what is the appropriate treatment for that particular condition. So I think taking the time to evaluate these patients appropriately is an important thing. So first and foremost, what should we do if a patient is sitting in front of you? That's the question that whether you're a child psychiatrist or forensic psychiatrist, if you have an older patient sitting, you're going to take care of them. First and foremost, history. You have to get information from the patient if they're able to provide it, and also from a knowledgeable source, a collateral source who knows them. It's a caregiver, it's a family member, it is a physician, it's a nursing home staff, whoever it is. And then you have to see, has there been a decline in cognition from the previous level of functioning? So that's what dementias are acquired illnesses. So the cognition in these individuals declines over the course of their lifespan, which is different from intellectual disability, kinds of patients that you might see in your clinic. These people have cognitive deficits at birth and they remain static. And as they grow older, they may have greater risk for dementias. But in dementias, these people have normal cognition and then it declines as they age because of many reasons, biological, psychological, social, all of them mixed together. So first and foremost, you have to get a good history, see if there is a decline in cognition, then find out if there is a decline in function, and then see if there are behavioral symptoms that emerge. And you have to do a good psychiatric history anyhow. Do these people have previous psychiatric problems? I mean, because depression, anxiety, post-traumatic stress disorder, schizophrenia, bipolar disorder, all of them are risk factors for developing dementias. So you need to rule out psychiatric illnesses. Then you need to rule out medical illnesses. Are these people having any medical illness? A history of cerebrovascular accident increases the risk of dementia. History of Parkinson's disease increases the risk of cognitive decline. Hypothyroidism increases the risk of cognitive decline. So ruling out medical causes. Medications, many of these medications that older people take, including the antihistamines, the benzodiazepines, the pain medications, can hasten the onset of cognitive decline. So a good medication reconciliation. Then do a good mental status examination to rule out or rule in whatever you're suspecting is going on. And then a mental status examination with a cognitive evaluation and screening tools. And most of the screening tools like the Montreal Cognitive Assessment, the Mini Mental State Examination, the St. Louis Mental Status Examination. These are all screening tools. They're not diagnostic in themselves. They tell you if the individual has a cognitive issue and is it below the norm for what, for that age for that patient. And then, of course, you have to do a medical workup, do the lab work, order MRI scans if needed, order a PET scan if needed. And then also, if you're in doubt, if you're not sure what's the issue, you order neuropsychological testing. And I always say this in all my lectures, is that in my area, neuropsychological testing is the best bang for the buck. What it does, it helps you differentiate between normal aging versus neurocognitive disorders. It tells you, differentiates between the different etiologies for neurocognitive disorders, whether it is Alzheimer's disease, vascular disease, frontotemporal lobar degeneration, dementia with Lewy bodies. And then it also can differentiate between depression-associated dementia. We used to call it depressive pseudo-dementia. There is nothing pseudo about it. The changes are transient, but the changes are very real. And versus, a neurocognitive disorder or progressive dementia. So that is the workup. So you have to do all of these steps. And the thing is, prescribing an antipsychotic medication, I think it's a major mistake, because the agitation may be underlying a pain. Patient may be in pain. The patient may be constipated. So that is actually going to make the situation worse not better. So I think we need to be a little more cognizant, rule out the etiology, whether it is primarily due to an underlying medical or a psychiatric condition, or it's a primary neurocognitive disorder, and then decide, okay, is this depression? Is this agitation? Is this psychosis? And then treat or prescribe appropriately. And we are now starting to have medications which are helping us differentiate and appropriately treat those things. Like brexpiprazole is an atypical antipsychotic which you can use for agitation. Then now you have Evuity, they have an indication for treating agitation and Alzheimer's disease dementia. So you're starting to now have repurposed medications for this condition. And I think you will have many more of those medications coming into the market, which you use when you non-pharmacological management, like redirection, reminiscence therapy, pet therapy, music therapy, all are primary because they help minimize the use of medications. And then as an adjunct, you can use medications when those non-pharmacological managements have not been effective. So that's the basic algorithm I go through every patient when I see them.
So I really liked another kind of like takeaway from when I was reading was that behavior is a form of communication, right?
Absolutely.
Um, so with that, and like we said, there's behavioral symptoms. Symptoms will often fluctuate. The cognitive symptoms are usually pretty steady kind of decline. How, when we're working with families, or again, even clinically, like how do we shift from going to how do I stop this behavior to what is the behavior trying to tell us? I think you were touching upon it a little bit there with, yeah,
Right. So the thing is that in the article it says that the behavioral symptoms are not consistent and they will fluctuate. Psychomotor agitation is the most persistent, but in Alzheimer's disease, apathy is the most common symptom. So again, what you need to do is tell patients and their families that there is no one medication fix for all of this. So that is why a good initial evaluation with regular follow up with the patient and their family members is the key to that. So don't fire and forget. Don't just give one medication and then expect all the behaviors to be treated. And you would see that often. Somebody has prescribed an antipsychotic and the symptoms have completely gone away, but the patient is still taking the medication 2 years down the line. It increases the risk of cardiovascular morbidity and mortality, cerebrovascular morbidity and mortality. So why do that? So regular follow-up. It depends upon where you are. If you're in the community, every 4 to 8 weeks, if you see the patient, at least have phone contact with them in between just to help them through that time. If you're in a nursing home, usually it's once a week. If you're in an assisted living, once every week or every couple of weeks. So, right, good evaluation with good cadence of follow-up, I think is the way to treat these individuals, because symptoms may not be there consistently, but different symptoms may emerge. You may have psychotic symptoms for a few months, then you may have anxiety, then you may have depression. So one medication is not going to fix all of that.
yeah. Based on what you've done, kind of what you've seen over the years, and again, you mentioned a whole bunch of other things that it can be besides like pure dementia, but what are the most commonly missed kind of contributors that are out there? And then how often is the agitation more an underlying medical condition that people are not understanding not seeing it?
Right. So important thing, like we talked about in the beginning, there are the A, the B, and C's of neurocognitive disorders, right? So the behaviors can emerge at any time, and the behaviors can be either primary, that is inbuilt into the natural history of the dementing illness because of all the neurobiological changes that are happening, or they may be secondary due to either a psychiatric condition or a medical condition. And history is going to help you, hone in on what is exactly going on. So talk with the family members, reviewing the chart, doing lab work will tell you, okay, this may be why the patient is agitated. Like I said earlier, constipation, pain, urinary tract infection, pneumonia, can all cause these symptoms. So getting a good history, deciding on which is the etiology, the primary etiology, trying to address that, and then closely watching and following up, doing rating scales to quantify and qualify those symptoms, And then if there's no improvement, going back to the drawing board and saying, okay, what am I missing here? Is this something else that is going on? And I think having a good high suspicion for an underlying medical or a psychiatric etiology, I think will help us minimize unnecessary prescription. That's what you want to do. Remember, most of older adults use polypharmacy. That means more than 5 medications at any given time. Many of these medications are probably not prescribed over the counter. And then if they're prescribed, they're probably prescribed without an appropriate indication. So, you have this complex problem with when you're dealing with them. And people double up on their medication. Oh, did I take my medicine today? Oh, I forgot. So then they double up or they forget to take it. So you have to walk through all of these things and make sure that the prescription is being monitored. How often are secondary conditions? I think in about these individuals, about 40 to 50% of the time, the agitation may be secondary
Yeah.
to different conditions. So suspicion for those are very important.
Yeah. It's not an insignificant amount. Again, like you're saying, just about half of the time almost
Correct.
that is a contributing cause of it or the origin of the cause.
Correct.
So pivoting a bit, so like talking about care management, I know you talked a bunch about the non-pharmacological care. Before kind of jumping into reviewing those ones a bit,
Yeah.
why do you think that these non-pharmacological care receives less attention than the medicines? Is it all just big pharma telling us to do this?
No, I would move away from that political debate. For me, our colleagues in the pharmaceutical industry are very, very important to us. These are expensive medications. They take a long time to develop. There's a lot of investment that goes in, and the trials are done with good intention. How people interpret that is completely different. So, that's why every month I do a critical appraisal and we publish it in a psychiatric times looking at each of those studies, because for me a good systematic review of the data is important. People may misinterpret, but data doesn't lie. The data can be used differently. So I would move away from that political debate. The reason why non-pharmacological management is so difficult to do, first of all, it is time intensive. It takes a long time. Two, it is labor intensive. You need people to do it. Three, to get that effect, you need a whole village to be working around it. So because of the logistics, it's just not feasible to do. So I think they are great when you have them available, and if there are dedicated family members or dedicated nursing home staff who are interested in doing it, the outcomes are great. But in a situation where there is an aging caregiver who really cannot do all of those kind of things, then it becomes important for us to understand that. Giving it to somebody who just cannot do it is not going to work because they're not going to apply. So what I do is I tell them that every interaction is a non-pharmacological management, even a normal conversation. If the patient is forgetful, getting into a heated debate about something that person cannot remember, it's only going to agitate them. So the thinking and the feeling parts of the brain are different. Although they're connected, they may not always be connecting in a person with neurocognitive disorder. So what happens? The input comes in through the thalamus, goes into the amygdala and the hippocampus, and people get fired away. They're irritated. They're annoyed. Their blood pressure goes up, but their frontal cortex cannot tell them, "Hey, this is not a threatening situation. So calm down." What happens in PTSD? Same thing. People react, and then the agitation remains. So I always tell caregivers, patience is a virtue. If the individual with neurocognitive disorder is saying something that is rude, inappropriate, agitated, brush it off. Roll with the punch. Don't take it to heart. That is not the person saying it. It's their illness talking. So understanding is, I think, the biggest thing. And clear evidence suggests education is the center of non-pharmacological management. A well-educated caregiver or a well-educated staff is worth their weight in gold, because they will roll with what is happening and not take it to heart and not further distress and not engage in those kind of things. So if somebody's saying something rude, talk about something else. That's part of redirection. If somebody's like agitated and wanting to push out of that, distract them. Hey, look over there. What's happening? So those are very simple things. So Education is one thing. So I do a lot of social prescribing with my caregivers of, hey, I know it's difficult. I know it's hurtful. I know you want to cry when this happens or say something. It's not going to help the situation. So our goal is to redirect and then see how we can calm the person down. Uh, of course, then, if it's too difficult to deal with and, they're causing impairments in the person's life or safety issues, then of course medications are what you want to do. And again, for medications, it is start low, go slow, don't keep on going. Because you don't use the same doses as you would do in a young adult because the physiology is not the same. The older patient is going to react much worse than a younger patient. I've seen people giving 10 milligrams of olanzapine for an older, frail person. That's just going to cause more damage than benefit.
Yeah. And just to clarify, I tease a little bit here and there with the jokes. So I know very similarly when we're talking about, again, on my age patients in regards to like kiddos on the autism spectrum, again, I would love to avoid prescribing medications and I would love to have all the services in place. The ideal school for them, therapist, a trained therapist, experienced registered behavioral therapist, RBTs that may be with them and spending time with them and really making those changes around them. But when, just like what you're saying is, we just don't have staff, right? We just don't have the manpower. We just don't have the ability. You know, Parents at times are getting assaulted by the kiddos, and it's like really, really hard. And then we have to kind of reach. That's when we get to a point of being like, okay, maybe medication is what we have to do instead of all these other non-pharmacological options.
And documentation is so important in that case. If you and I always say, who are we giving the medication and what are we giving the medication for? If the patient is not sleeping and the caregiver has to go to work in the morning and the person is up at night and the caregiver is completely exhausted in the morning, you're not affecting one person, you're affecting an entire family. So being very aware of why you're prescribing is important. So again, it's a team effort with the patient and the caregivers being center of the team. I think that's where meeting with the patient, meeting with their families, working with them is so important because you're being respectful and trying to deal with the issue and not look for a one-stop solution. And I always tell them, I know it's difficult, but we are here in this with you. If this medication doesn't work, not a problem. We'll try other things, and we'll work with you on that. So you're never going to let them set them adrift. You are always going to be there, tethered to them, working with them, no matter how difficult the situation. And it also challenges you to provide the best possible care when the situation is very difficult. And that's what I always say. Where when things are at their worst, I'm at my best as a physician and as a psychiatrist. All my senses are honed into how can I be most helpful to the patients and their families.
I think, again, for going on to some of the pharmacological, some of the non-pharmacological treatments we've talked, and you're saying these are, again, first line treatments, things that we want to focus on first
Right.
as doctors and physicians, as you know, exercise and caregiver education. There are some of the other ones that I think people may think of as more woo-woo, a little kind of holistic-ish or a little out there kind of treatments, but they're very evidence-based. Things like you're saying, music therapy,
Pet
aromatherapy.
therapy, absolutely.
Yeah, tell us a little bit about those and I guess some of the benefit of those. Yeah,
Yeah, so if you look at the network meta-analysis that have been done, and there are many over the last decade they all show benefit. You can't choose one over the other. The best part of those is that they all seem to work. They all seem to have an immediate effect and a long-lasting effect. And there's the booster effect as well. So if you keep teaching skills to the caregivers, they will be better at it. So they'll adapt, they'll adopt, they'll do the different things. So I think non-pharmacological management is the center. Education is the core value here. You're educating the caregiver, you're educating the patient. And then a better educated caregiver is a much better caregiver. So you can't pick one over the other. Whatever is available, you try to implement. Even a simple thing as redirection, simple thing as education. More, hey, neurocognitive disorders, behavioral symptoms are inbuilt into that. So don't take it as if it's something separate. It's part of the illness. That simple thing will be like, oh, this is why the illness is. So it's not my mother or father or spouse being nasty. It's the illness that's making them behave this way. So a simple thing as that, acceptance is a very important thing. Redirection. Then if you have ability for music therapy, reminiscence therapy, there are so many different things. Pet therapy, they're all beneficial. And the best part is no side effects. People don't fall because of music therapy, unless of course they're dancing vigorously, something of that sort. But there is no clear adverse effects from these, and you can build on these skills. So there is that layering of knowledge and skill that happens with time.
I remember seeing like a Netflix documentary, one of those explained about music therapy. And again, one of the main uses was with geriatric population, how, and then getting up and dancing a little bit as much as they're able to, and how, again, yes, there is evidence which shows that it can be helps with behavior, cognition, physical health as well. So it's definitely something I remember. I just remember seeing this like many, many years ago. So this is like definitely has been out there for a while. And I think, again, people just don't utilize it as much, right? We don't keep it
Yeah,
in our toolbox.
and it also helps the caregiver, right? It's something as a team that the caregiver and the patient can do. You know, going dancing, that's great. Exercise, water, hydrotherapy. These are all effective things. And how do they work? I think it works by integrating the sensory activity together, and the neurons fire more. There's more social connections, and I think that's how it works. And that may be oversimplifying it, but that's how I think. I explain it to the patients and the family members how these kind of things work. I mean, for example, reminiscence therapy, going through photographs, going through videos. These are all things remembering the good times. They evoke positive memory. They evoke a sense of cohesion, like a sense of family, a sense of belonging, which is good for the patient. These individuals have a lot of stress, especially when you're aging, because you're losing your independence and you're depending on other people to be taking care of you. I would be terrified. That's my biggest fear is I'm a very independent kind of person. If I have to depend on other people for my daily life, that's a very scary thought for me. And every time I see an older person who's demented, that's the first thought that comes. How can I be a non-threatening presence and help them maximize their function? So that's why healing is part of the important thing. So I'm not providing. I'm healing a lot of the things that people are afraid or.
Let's talk about medication a little bit then.
Sure.
So, brexpiprazole, one of, again, the newer ish kind of antipsychotics out there, that seems like it's maybe the new king of what we should be using. Is that
I
correct?
wouldn't. I definitely wouldn't say that.
Okay.
There are before Beck proposal came, and the company did a great job. They have 4 randomized control trials, very similar to each other, and they were very specific in what they were looking at is for agitation in Alzheimer's disease dementia. So agitation is not the only behavioral symptom. So apathy is, depression is, anxiety is, psychosis is. So for specific indication, both brexpiprazole and Ability, which is the dextromethorphan bupropion combination, have been FDA approved for that because they have shown benefit, and they are short-term trials. There are 12-week trials. So they're short-term. The downside to it, it's not going to work for everybody. So for agitation, it'll work. For Alzheimer's disease, dementia, agitation, it'll work. But what about frontotemporal dementia? What about vascular dementia? What about dementia with Lewy body? So it's not going to work. So I think the physician should know that non-pharmacological management remains the center. But for specific indications, these 2 medications are highly beneficial in those individuals. But they're the short-term solution. They're not. You can't prescribe them for 2 years. There is no data. And if you have emergent agitation, that these are psychiatric emergencies, they're not approved for PRN use. They're not approved. They don't have an intramuscular or intravenous preparation. So you may have to go to the other medications like IM olanzapine if the patient is agitated, or IM haloperidol. And those you would do in the emergency room or the inpatient psychiatric unit. So for emergent agitation, I wouldn't recommend these medications. But for non-emergent agitation in Alzheimer's disease dementia, yes, definitely. They are one of the two choices. But there are other medications that are also beneficial because antidepressants, the citalopram trials were positive. There is the Cochrane review that looked at, citalopram and sertraline being beneficial for agitation. They're beneficial even for psychotic symptoms because although the psychosis phenotypically, that means in terms of appearance, looks very similar to psychosis and schizophrenia, but the neurobiology is different. There may be more polymorphisms of the serotonergic receptors or dopaminergic receptors. There may be cholinergic deficits leading into that. So newer medications will come, and I think people are trying to use some of the other medications. Like Cobenfy is a great example. There are, I think, 4 ongoing trials of Cobenfy for agitation and possibly psychosis. We're waiting for those results. So again, newer medications or repurposed medications are coming into play. So again, one size does not fit all.
Yeah. And the other treatments are things like the cannabinoids and
Yeah,
how they're starting to get a little bit more discussed in dementia care. Like what?
yeah. And
Yeah.
dronabinol is the one that has been tried more often. It's the synthetic cannabinoid, and there's data that it is beneficial in decreasing agitation. And it's very well tolerated. There was a recent trial that showed positive benefit, and meta-analysis have shown that there are, I think, 2 meta-analysis that I have sort of noted in the article, which have been positive. So again, early stages, but the issue is acceptability. I mean, every time you use cannabinoids, everybody's like, oh my God, is my grandmother smoking pot? No, you're not talking about street drug. You're talking about medicinal value. It's an FDA approved medication. And so acceptance becomes an issue. So it's lowered down the algorithm of where we use it. But then if you've tried all the other medication that's not beneficial, absolutely worth a try. And I think it's 2.5 to 10 milligrams is, I think, the dosing that you can do for these individuals. So I have tried it with benefits in certain cases. So again, one size does not fit all.
Yeah. Always. I think that's important to remember is like look at the patient in front of you and the system around them and make your choice from there. So
Correct. Treat the patient, not the symptom.
yeah. Yeah. And the other kind of interventional treatment that a lot of people I think forget or overlook is ECT.
Right.
Yeah.
Or any kind of interventional treatment like
Yeah.
ECT, TMS, direct stimulation, all of them are starting to emerge as good treatments. Again, availability, acceptability, and adaptability. 3 A's that I always talk about. ECT, as you know, is the most effective treatment for many conditions, including refractory depression, refractory schizophrenia, bipolar disorder. But we don't use it because it becomes a political debate. People make a big deal about it, but the evidence. I trained in England before coming to the US. We used to use ECT all the time. Very safe and effective treatment. Modern machines are very safe. We use the right unilateral ultra brief pulse ECT. Very safe in these individuals and very effective. And you're not doing it forever. You're doing a short course to help with the agitation, beneficial. TMS, emerging data that is actually not only helps with behaviors, it also may help with cognition. And various different versions of the TMS are going to come out, which may show benefits in the long run. Again, it's the adaptability, acceptability, and availability, so that you have to do that. If it is available, would I consider it as first line treatment? Probably not. We have developed an algorithm where you use, cholinesterase inhibitors, memantine as a first line. Then, if the patient is still agitated, we may use, Avidity. We may use brexpiprazole. We may use risperidone. We may use, aripiprazole. We may use olanzapine, quetiapine. If those don't work, then of course cannabinoids, ECT, TMS are all in the game at that stage of the treatment.
The other part of, again, dementia care is, again, the caregivers. We've been talking about the caregivers, right? We've been talking about them as like, oh, part of the team. How much should we be looking at the caregivers themselves as well to be like, hey, let's get you some care and the burden that this is on you? And how much is bringing out of you. I know I talk about a lot with my adult patients, like caregiver fatigue and the burnout that occurs with that, and how much that just wears on everybody. So, what can we do to help support the caregivers as well?
And so remember, this is a team effort. It really does take a village to take care of an older adult with a psychiatric illness, whether it's neurocognitive disorder, depression, bipolar disorder, schizophrenia. So I think that understanding is very important when you're seeing these patients. So a rushed assessment where you're just not paying attention to the nonverbal cues, what's right in front of you, I think is a mistake. I think rather than just gathering information and making a diagnosis and then giving some medication is not going to help in the long run. So pay attention to the patient, pay attention to the caregiver. Always ask how the caregiver is doing dealing with the situation. And caregivers often are exhausted. Caregivers often are upset because they've gone to other providers who have not given them the time of day and probably made them feel bad. So I always, I'm doing the healing part. I'm just listening because within 10 minutes of the patient and the family providing, I know what I'm going to do. So I'm just confirming or eliminating the doubts. So I spend a lot of time talking to the caregivers on simple techniques and taking care of them. And if they need to see somebody, we always provide them with the resources for them. And then, of course, Alzheimer's Association, area agencies on aging are all there to help. So it's a team effort, not an individual effort, but paying attention to both the patient and the caregiver is important. If the caregiver is not going to be well, the patient is never going to do well. So you have to remember that.
Yeah.
And I always, like I said earlier, patience is a virtue. Just being able to sit and take it in and say, okay, how can I be most helpful to you?
Yeah. We're talking, I mean, about also guidelines and ideal ways to treat, right? And, this is unfortunately the word ideal comes in there, right? Because we know reality is not always plays nicely. And kind of like we mentioned before, just limitations, whether it's manpower, finances, whatever else it may be, like, how do we avoid getting into situations where we're like, here's the guidelines, here's recommendations, and then nobody can put them into place? How do we support that?
Right. See, guidelines are for me like a map. They tell you here is the basic ingredients or basic way of how you can proceed. Then you need to figure it out, and you have to treat the individual in front of you. So I use the guidelines as my roadmap, but with the reality situation. It's like driving on a rainy day is different from driving on a snow day. Is different from driving in bright sunlight, right? So you have to use it may be the same map, but it doesn't tell you the ground reality. So I use the ground realities to see what is in front. I am more cautious than ever before. Over the last 25 years as a attending geriatric psychiatrist, I have become more and more cautious with giving medication. So I give only when I absolutely have to give medication. So, and I'm a minimalist. I try to not give too many different things, and combination treatments only if monotherapy trials have really been unhelpful. So a lot of gathering information before the patient comes is also done, the chart review and talking to other providers. And then giving medications along with little tips on how to the non-pharmacological management is what I do. And frequent follow-up, once every 6 to 8 weeks possible. In nursing homes, much more than that because people are more demented, more agitated, and have more polymorbidity in those situations. So again, you adapt to the basic ground realities, but always stick to the rules. I'm not going to do polypharmacy. I'm going to always use non-pharmacological management first. If I can add pharmacological, great. I'm going to monitor, start low, go slow. I think these are just, things that it's like a checklist. You go through those. I'm not going to do this. I'm going to do this. I'm not going to do this, do that, which will prevent you from overreaching and causing harm.
Yeah. I'm like realizing as we talk more, and there's a lot of similarities actually between like geriatric psychiatry and child adolescent
Oh,
psychiatry,
absolutely.
especially
Absolutely. Yeah.
especially when I'm working with a lot of the developmental disability patients and the families that are out there. And something else kind of like came to me. It was I also agree with you that I try to do everything else first, and medication is like a last resort. And we don't want to bring out the quote unquote big gun medications, on
Right.
again, on my end, the Abilify, Risperdal, the antipsychotics, etc. Again, because of concerns about black box warnings and then some of the effects, cardiac effects that it has. But then I run into situations where we wait, we wait, we wait, we wait, we delay prescribing, and then eventually at some point in time we prescribe it, or we almost feel like we're forced into prescribing something, and then parents are like, "Oh, this made such a huge difference. We should have done this 6 months ago, a year ago. Why do we delay?"
Right.
What?
See,
What? Yeah,
so
yeah,
Dr. Mirza, it's not as simple as that, right?
right.
So the ground realities are the ground realities. If you
Yep.
think that, so for example, a patient comes and you're seeing them in the emergency room, the patient is swinging the chair, using the butter knife to try to stab. That's an emergent situation. You have to use your medications. You start, you treat, you monitor, and you taper off and discontinue. So that's an emergent situation. Also, when people say, "Oh, we should have used it then," but you are monitoring the situation, so it may not have been feasible at that time to use the medication. You have to really go through that. That's why I always say treat the patient, not the symptom. Each stage is different, and you're getting more and more information. And if you find a great medication, that's wonderful. Uh, and chronic disease management is very different. I always say it's different for us who manage chronic diseases than from an orthopedic surgeon who's curing or doing surgery for a broken bone. That's very different. So let me give you an example. So if you tell a patient with diabetes, "Hey, go take this GLP-1 and your diabetes is great," doesn't do squat. If there is a whole social prescribing that needs to happen. Hey, you need to take care of your eyes, you need to take care of your heart, you need to take care of your kidney, you need to take care of your toes, you need to eat healthy, you need to stop smoking, you need to decrease your alcohol, you need to lose weight. That's the point. A medication is only as good as the plan which is put in, right? It's like putting a great engine on a car which has bad transmission. It's not going to run. So I think we miss. I think in this looking at the parts, we miss the whole picture. So I always tell my residents, focus on what's right in front of you, because there's a lot of things that are unsaid and you need to know. Caregivers may not tell you all this stuff. So asking them, how can I be most helpful, and just be willing to listen and then adapt to the realities of what is in front of you. Sometimes you may need to use medication. There are times where I have had to use medication right as I'm like, hey, this needs to be treated now, because safety becomes an issue. So I think just adapting and listening and adapting, I think, is the way I would go.
Yeah. Last kind of question. Dementia care, again, like a lot of people focus again on the memory loss and let's slow memory loss, let's slow memory loss. And again, with what we're talking about more, we're looking at quality of life, preserving quality of life as much as possible. But how do you define success when you're treating these behavioral symptoms of dementia? What does that look like for you?
That's a great question. So again, success is in each patient is very different. So I talk to the patient, the caregiver, and then we come up with what we would rate as being successful. So is it reduction of symptoms? Is it decrease in the caregiver's stress, or is it improved functionality, or is it all of those things together? So again, we would put, and success is different at different stages as well. Once you're severely demented, just not hitting the caregiver may be considered a major success. Whereas if you're mildly demented, being functional, attending activities for the family, decreasing irritable outbursts, maybe all of those. So again, depending upon the stage of the illness and what the patient and the caregiver wants, you adapt success based on that. But I would never have it my success. I consider every treatment, whether they're successful or not, as a successful intervention, as long as I am able to understand, appreciate, and provide support and provide healing to the patient and the families. I find this as very successful. Even the worst outcomes, sometimes I'm like, I tried my best. I did everything that I can. That's why having a checklist, having a guideline, a protocol, and having constant feedback, of what you did right and what you did wrong. So with our residents, every afternoon from 4 to 5 o'clock after clinic, we do a deep debrief. You need to really know how you did in the time you spend with the patient, which is I think one of the most powerful tools that we have, because you have to learn from your mistakes as well.
Yeah, I think that's very important. And I think, oh, well, I do my usual last question, and I think you kind of segued us naturally into there is as a healer, right? As somebody who does the healing work and working with this population, which is extremely, extremely challenging. What is your self care? What is your self healing?
Yeah, no, people ask me that all the time. As I age, mortality becomes a very real thing for me. Issues associated with aging becomes very real for me. And I always say, full life is what you decide it is going to be. So I do a lot of things that I always wanted to do. So the bucket list I could keep doing. Driving to work and driving from work and decompressing myself and playing out what my day is going to be. And then at the end of the day, I'm going through what my day was and learn from that. So I think I'm a better human being, a better psychiatrist, a better geriatric psychiatrist from the day before. It may not have been a perfect day, but it was the day from which I learned. Sometimes you have lots of not so great news, but you know what? It's not going to put me down. So self-healing is what I have learned to do. And I do a lot of other things outside. I ride my motorcycle. I watch whatever I like to watch. I like podcasts. I like reading, and I'm constantly learning and evolving as a human being, which I think makes me a better psychiatrist. I'm well-rounded. Like I said before, I'm very cautious with medications because I know all the good and not so good things that come out with medication. So it just makes you, I think, more aware, and it brings humility to you because you may not be able to help everybody, but you're going to definitely try.
Yeah, I think it's a great message. I think it's important for us to like do all those things. I know my voice is a little bit different today because I was out screaming at a concert last night. So like, like you said, getting those one of the bucket list groups off my list. And I was like, I have to do that. So that's very, very important for us as well. So thank you, Dr. Tempe, so much for your time and your work that you do.
Thank you very
Um,
much, sir.
yeah, I thank you for the conversation. And for everybody else, this is the August special report podcast on the Psychiatric News. You can find it in the August issue online and in print. Remember to rate, review the podcast, give us 5 stars, and we will see you next month for the next September special report. Thank you so much.